Should we start, Abhishek?
Yes, ma'am. We are live now. Just I'm sharing the screen.
Yes.
We are good to go, ma'am.
Yes. Very good evening to everyone. I welcome one and all to this Public Awareness Committee of Foxy webinar, episode number 15. Today's webinar is with the East Zone. So we are having esteemed faculties today on board. So before we begin, we would like to take the blessings of the Almighty by playing the Ganesh Vandana. Abhishek, please go ahead.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्ति.
Thank you, Abhishek. I welcome all of you on behalf of Dr. Priyankur, Dr. Monica, and myself. Our chief guest for today is Dr. Rishikesh Pai, sir. We'll take sir's blessing as and when he joins. And our guests of honors for today are Dr. Shamal Sheth, sir, and Dr. Pragya Mishra Chaudhary, ma'am. Abhishek, can we have Shamal sir CV, please?
Yes, ma'am.
Yeah. Dr. Shamal Sheth, sir, is a senior consultant and practicing gynecologist at Kolkata. He is the visiting specialist at Woodlands, at Bellevue Clinic, as well as at Zenith Super Speciality Hospital. He has been the managing committee member and office bearer of the BOGS for over 13 years. Also has been the honorable secretary of the BOGS between 2015 and 16. And he's currently the vice president of the Bengal Obstetrics and Gynecological Society. We welcome you, sir. And I would like to have a few words of motivation from you, sir.
Thank you very much for inviting me as a guest of honor. I think this Public Awareness Committee has been working superb for last several years. And these days we are in a time that public awareness makes an integral part of our day-to-day practices or day-to-day life, especially in improving the healthcare of our women, our mothers, our patients. And when it was a few years before also, I was aware of the activities of the Public Awareness Committee when I was the chair of the committee of the MTP committee of Foxy still then, and now it is in the hand of my own younger brother Priyankur. He is a very enthusiastic, a very vibrant person, and I think he will be doing much more better. And there are several topics of discussion which are of so relevance in our day-to-day practices. You know, this today I came across a video. It was showing at a place a baby has been delivered. The baby has been held between the feet in a position upside down, and the baby is shown having held with its hands the baby tray, and that has been video recorded. So and that has been shown for several seconds. I don't know how it is practicable or so. Now we are having a discussion on a baby-friendly labor room or baby-friendly delivery environment or whatever kind of thing. And another discussion is micro and macronutrients. These are of immense importance to our practices, to the nutrition of our mothers. We all are aware about it, and we need to make our mothers aware of all these things. We'll have a good panel discussion on anemia. You know, anemia is a never-ending topic. In every conference for last so many years, since the time we have learned something on medicine, we are hearing anemia, anemia, anemia. This is never going to be. Our president is so vibrant, and he has started his journey of his presidential career with an anemia prevention program. He started that Jatra, you know, that Jatra came to our Calcutta when we are having our AICOG. So many efforts are being provided by the Foxy, different committee chairpersons, Public Awareness Committee, and we need to go on, we need to continue all these things. So such a nice program, coordinated, And I believe everyone who have been participating will be of some kind of benefit, whichever way it is possible. And I'll try to attend the program as much as possible. Thanks to all of you. Thanks to Priyankur. Thanks to Dr. Rishikesh Pai, our president. We love him like anything. He's a good friend of mine. And thanks to all of you for calling me as a chief guest, a guest of honor. Thank you very much. Thank you very much.
Thank you so much, sir, for your time. Your words really mean a lot. Our next guest of honor is Dr. Pragya Mishra Chaudhary, ma'am. Ma'am is a consultant infertility specialist at New Life Test Tube Baby Center and MGM Hospital and Research Center at Patna. She is currently the Secretary General of ISOPAC. She has been the chairperson of Genetic and Fetal Medicine Committee. She's also been the founder secretary of the Bihar chapter of ISAR and has been the vice president of the Patna Obs and Gynae Society. And she has been awarded with multiple awards, including the Healthcare Professional of the Year 2018 by the Bihar. We welcome you, ma'am, and we would like to have a few words of motivation from you, ma'am.
Yeah. Thank you so much. Well, sorry, I'm having to, log in through my mobile because I don't know, somehow the laptop is still taking time. So I've just, I think, I hope you can see me, right?
Yes, ma'am. Yes, ma'am. I can see you.
Okay.
Very elegantly.
Okay. Thank you. Yeah. Well, first of all, I would say that, I would really like to thank the Public Awareness Committee for having invited me as the guest of honor for today's program. It is indeed an honor. Actually, I can see that I have logged in. Can you give me just 30 seconds?
Surely, ma'am. Yes, ma'am.
Yeah.
Supriya ma'am, good evening.
Good evening, Apurva.
Syamal ma'am. Syamal sir, Pragya ma'am.
Yeah.
Good evening, Apurva. Best wishes.
Yeah.
Thank you, sir.
So, I'm Dr. Chevelle, the chief guest of today's function.
Ma'am, you have to switch off one of the devices. Oh.
So the chief guest of today's function, Dr. Rishikesh Pai, although I can't see him, perhaps he's going to log in later, or
Ma'am, he said he'll be joining as and when he finds time, ma'am.
okay. And guest of honor, Dr. Shamal Seth, who is indeed a very good friend of mine, and I've known him since years, and he's also the VP elect from East Zone, Proxy. So, Public Awareness Committee Chairperson Priyankur and Apurva, who has worked so hard, for this program, and Monica. So, thank you so much for having invited me. Well, I heard a little bit of what Dr. Shamal said, but basically what I feel that, we treat our patients and whoever comes to us. But it's very important, to create that awareness, because unless and until there is awareness, regarding, a treatment which is available, the patients are not going to come to you. Whether it is, even say, we talk about cervical cancer also related to HPV vaccine. So now, unless and until the patients know that there is something like a vaccine which is available for prevention of cervical cancer, she won't come to you. So, so the role of public awareness committee is very, very important. Now, anything, whether it's the prevention of anemia or whether it's prevention of, treatment of heavy menstrual bleeding, anything, I think the role of the public awareness committee is just paramount, and we just cannot sort of undermine its role. So I've seen the program today. The topics which have been selected are very good. And, the panel, which is going to be moderated by Dr. Supriya Jaiswal and Dr. Rekha Jha, and the esteemed panelists also. And I'm sure they're going to do indeed a wonderful, they're going to make the program quite, lively and interactive. And the brilliant speakers that you have today, along with the chairpersons. So, I just feel that, again, I'm just reiterating to the Public Awareness Committee that, they should keep up their good work, just try to create awareness as much as possible, in relation to women's health. So, all the newer things which have come, especially, in the field of fetal medicine now. A lot of people, now even in India, there are centers which have started doing surgery for, in vitro surgery. There are a few centers. So unless, the doctors are aware of these kind of treatments, how are they going to inform their patients that, okay, if your baby has something which has been detected in utero, you can always go to such a center for your treatment. So I think you can create awareness in that aspect also. I mean, this is just an idea, that related to fetal medicine and prevention of neural tube defects. So it's quite an important aspect of women's health, and so you should create an awareness, in those aspects also. And once again, I would say thank you for having me for this program as guest of honor. Thank you so much.
Thank you so much, Pragya ma'am, for taking the time out to join and give your words of motivation for us. We would also take this opportunity to thank Dr. Madhuri Patel ma'am, our Secretary General, Dr. Alka Pandey ma'am, our Vice President, Dr. Kalyan, the National Coordinator, as well as Dr. Rekha Jha ma'am and Dr. Indranil, who are the coordinators and have been doing excellent work throughout the year. So we would now proceed to the session. Our first session today is a talk on micro and macronutrients in pregnancy by Dr. Apurva Datta. The chairpersons for the session are Dr. Pratima Devi ma'am and Dr. Samreena Kamal ma'am. Can we have the CV slides, Abhishek? Yes, Dr. Pratima Devi ma'am is a consultant gynecologist at the Regional Institute of Medical Sciences at Manipur since 2007. She has been awarded with multiple awards, including the Rajwanti Rani Harihar Narayan Tiku Gold Medal Award. She is the master trainer for CAC, PPIUCD, SBA, etc., and also the Lakshya Nodal in charge of RIBS. We welcome you, Pratima ma'am. Our next chairperson is Dr. Samreena Kamal ma'am. Dr. Samreena is an assistant professor at MGM Medical College, Jamshedpur. Her fields of interest are laparoscopic surgeries, high-risk pregnancies, benign gynecology, ultrasound, as well as recent advances. Madam has been the organizing secretary in state-level conferences in various years, and also has been awarded as the Women Achiever in 2016 for her distinguished services in the health sector. I would request Pratima ma'am and Samreena ma'am to kindly carry on with the session. Our speaker today, ma'am, are you there? Pratima ma'am?
Pratima ma'am, you're on mute. Kindly unmute. Yeah.
Hello,
Yeah.
good evening to all. Myself,
Yes.
Dr. Pratima. I would like to call Dr. Apurva Kumar Datta. He's known to me also, and I would like to announce his CV. He's very known to each one of us. He is the National Coordinator for FOXY. He is also National Coordinator for Public Awareness of FOXY, Sexual Medical Committee, Regional Faculty, and Master Trainers.
Thank you,
of
Pratima
different-
ma'am.
Hello.
Thank you so much, ma'am.
Yeah,
Thank you
yeah.
so much, ma'am.
Having lots of experiences, and I'm very happy that he has also won lots of awards like the Dr. R.D. Pandit Research Award and Champion of Foxy Awards, and Kamini Rao, Yuva Orators, and many others. So I would like to call upon Dr. Apurva, and we can start the session. He will be speaking on the macro and the micronutrients on pregnancy.
Thank you. Thank you so much, ma'am, for just a
Mike
warm
is with
welcome.
you.
So at the outset, I would like to thank our dynamic president, Dr. Rishikesh Spicer, Secretary General, Dr. Madhuri Patel, Madam, Vice President in charge, Dr. Alka Pandey, Madam, and my dear friend and PSC Chairperson, Priyankur. Priyankur is coming to Dhanbad on 26th, so it's really wonderful to meet him in my society. So now I would like to begin my topic for today, the role of macro and micronutrients in the pregnancy. Now, my dear friends, we in pregnancy got a lots of advice from our, elders, घर के जो भी लोग हैं, है ना, we advise how to sleep, what to eat, how to eat, and number of other things. But actually, we have a lot of confusion that what is actually a balanced diet, what should we eat, what should not we eat, and what quantity, whether it's a micronutrients or it is a micronutrients, should we eat is always a much debatable topic, much confusion topic. Even many doctors are not aware how much amount should be given in each, because each and every pregnancy is a special pregnancy. Each and every pregnancy has a different, requirement. So this topic is very important, and I will very short highlight the important parts of this topic. Now, am my slides are visible? Yeah. So mother and baby both are benefited by good nutrition during the pregnancy, as these 9 months are the window of opportunity. The healthy pregnancy, the food eaten before and during the pregnancy, help preparing the body to support the growth of a body. Sensible eating gives a baby the best chance for a healthy beginning. And we all know when a beginning is good, you will win the half of the race or half of the match. So when the baby beginning is healthy, then definitely in the latter part of the life, the baby will be healthy. So it is very, very important to prepare our women to give a good nutrition, whether it's a micronutrition or it is a macronutrition, so that the mother will be healthy, so that the baby will be. Now, what is the nutrition during the pregnancy? The calories taken daily containing the micronutrients and micronutrients for the proper growth of the baby along with the healthy body of the mother. Now, question is, what is the healthy meal is? What, how, when? So, what is the healthy meal? The healthy meal includes all the food groups in the diet, whether it's a form of vegetables, the milks and dairy products, the cereals and grains, the meat, beans and eggs, the fats and oils. So basically, when we are advising to our patient that in your thali, there should be minimum of the 5 colors. So if the 5 colors is present in the thali of a woman, that means she is eating a healthy diet. Now, how to assess the proper nutrition? We assess the proper nutrition by the weight gain of the mother, the blood report of the mother about the hemoglobin, about the folic acid level, and other nutrition level, the growth assessment of the body clinically, and by ultrasonologically. So what is the optimum weight gain during the pregnancy? We know since ages that if it is underweight, that is BMI is less than 18.5, then it should be 12.5 to 18 kilos should be the ideal weight gain during the pregnancy. The normal BMI, it should be 11.5 to 16 kg. If it is overweight, that is BMI between 25 to 29.9, then it should be 7 to 11.5 kg. And when the BMI is more than 30, it should be less than 7 kilo of the body weight. So now coming to the first trimester. First trimester is very important because it is a time of rapid cell division, organ development, and preparation for demand of the fetal growth that occurs during second and the third trimester. We all know in the 6 weeks of the baby, it is just like a pea. And 7 to 8 weeks, the major organs are partially formed, the amniotic sac is formed, and the placenta is developed. So the critical nutrition is needed in the first trimester. The calories, it is either equal to the pre-pregnant state or a little bit of extra of the pre-pregnant stage. That is a calorie intake. But it should contain also the protein, the folic acid, the vitamin B12, and the zinc. Now coming to the second trimester. Now the baby start to hair. The sex organ start maturing. The hair grows. Baby can cough or have hiccups activity. So the critical nutrition needed is actually more, and the calorie needed is 440 kilocalories per day extra. It should also contain the protein, the iron, the calcium, magnesium, vitamin B, and omega fatty acid. The third trimester, the most of the sex organ get matured, the brain cells are growing fast, the calcium is needed for the bone and tooth growth. So the critical nutrition needed is the 450 kilocalories per day extra. It should also contain the protein, the iron, calcium, magnesium, vitamin B, and omega-3 fatty acid. Now coming to the macronutrients. Now what is macronutrients? Macronutrients are the nutrients required in larger quantity that provide us the energy. For example, the protein, the carbohydrate, the fat, and also the fiber and the water. The energy is required to maintain the maternal homeostasis while supporting the fetal growth. So macronutrients is also equally important. Now coming to the micronutrients. Micronutrients is the umbrella term used to represent the essential vitamins and minerals required from the diet to sustain virtually all the normal cellular and molecular function. The cell signaling, the motility, the proliferation, differentiation, apoptosis that regulate tissue growth, function, and hemostasis is actually the macronutrients is needed. So the important nutrients, the macronutrients are the protein, the carbohydrate, the fiber, water, fats. The micronutrients are the folic acid, iron, iodine, calcium, zinc, copper, selenium, magnesium, vitamin A, K, D, and other minerals. These are actually needed during the pregnancy. The micronutrients deficient and the pregnancy outcome. We all know if there is a deficient of the folic acid, it causes the neural tube defect. If the iron is low, then it causes the anemia, and anemia itself is a risk factor for the n number of complications during the pregnancy, including the hemorrhage and PPH. The iodine, it cretinism cause cretinism. The calcium, it deficiency cause the hypertension, the PIS. The zinc, it cause the anemia, low birth weight, anencephaly, neural tube defect. Vitamin A, it increases the chance of the vertical transmission of HIV, infant survival, maternal anemia, and also causes the infections. Now the protein. The benefits are it gives the energy. It is crucial for the general fetal and placental growth. It causes the proper digestion, growth of the maternal tissue, building of the breast and uterine tissue to support the growing baby, and build the DNA and special cell that make up the immune system. So recommended dose is 60 to 100 gram per day is the protein requirement. The source of the protein, we all know the vegetarian sources are green vegetable, seeds, grains, chickpeas, sprouts, soya, rice, quinoa, milk and dairy products. The non-veg are the eggs, meat, fish, etc. The carbohydrate, its benefits, it's great source of energy for the mother and the baby. They break down into the simple sugar-like glucose, which pass easily across the placenta and provide energy support to the growing baby. The recommendation is 175 to 200 gram per day. The source, we all know the whole grain, the potato or sweet potatoes, the brown rice, oatmeal, cookies, banana, cherry pie, cheese and junk foods, corn, soft drinks, sweets. Non-vegetarian include the eggs, meat, fish, and sheep. Fats, the benefits, it's give energy up to 25% from the fat. For the fetal growth and development, especially the brain, its a complication includes the higher intake of the saturated fats can lead to the preeclampsia, diabetes, gestation diabetes, and preterm delivery. So when we are advising fat, we should be very cautious. The source of fat, we all know the monounsaturated fatty acids are contained in olive oil, avocados, nuts oil, nut butter, ghee. The polysaturated fats contained in fish, nut seeds, sunflower oil, mayonnaise, egg yolk, etc. The water, yes, my dear friends, water is also very, very important. It's important because it helps in proper digestion, help in nutrients circulation in the body, maintain the amniotic fluid, and help in the detoxification. The recommendation, it's 2 to 3 liters per day, but again it's depend upon the climatic environment. If it is a cold, it might require the less, but it is a hotter place, it might require the more of water. The fibers, it keeps the digestive system running smoothly, important for the healthy heart, decrease the risk of diabetes, reduces the risk of preeclampsia. The sources are fruits, berries, green vegetable, grains, and flakes. So the macronutrients deficit and pregnancy outcome. In case of vitamin D deficiency, it causes the neonatal hypocalcemia. Vitamin K deficiency, it can cause the hemorrhage. If there is a copper deficiency, it causes the anemia, anencephaly, low birth weight. Selenium deficiency cause neural tube defect, brain dysfunction. Magnesium deficiency cause blood coagulopathy, toxemia in pregnancy, and preterm birth. So now coming to the iron, it is definitely very useful and it's needed for the RBC production and anemia prevention, for the fetal and placental requirement and expanded blood volumes. The best source is spinach and iron fortified with the whole grain bread. So daily requirement is 27 milligram per day. So we all know, these are the rich sources of the iron, the non-veg source, or in case of vegetarian, we have a broccoli, potato with skin, dry beans, green leafy vegetable, raisins, dried apricot, iron fortified with the cereals, and etc. Folic acid, it is need for blood and protein production, effective enzyme function, and prevention of the neural tube defect. The best source is again spinach and green vegetables. Iron fortified whole grain bread is again a good source of the folic acid. The daily requirement is 600 microgram per day. So the green leafy vegetable are good sources, the seeds, the nuts, the sprout, beans, pea, lentils, beet, bell peppers are a good source, and papaya and orange are the good source of folate. Calcium and vitamin D needed for the strong bone, teeth, vitamin D for absorption of the calcium. Best source is the milk, cheese, yogurt, spinach. The vitamin D, it is the sunlight and fortified foods. The daily requirement of the calcium is 1200 milligram per day, and vitamin D is
Nuts,
1000 units per
sprouts,
day.
beans, pea, lentils, beet, bell peppers are a good source, and papaya and orange are the good source of folate. Calcium and vitamin D needed for the strong.
Yeah. Iodine needed for the thyroid function and neurological development. It also prevents the mental retardation. Best source is again spinach, milk, and berries. It is fortified salt. Zinc is the maximum 34 milligram per day needed for the cell division, tissue growth in early pregnancy, to reduce the preterm birth, prolong labor. Best source is red meat, poultry, oyster, fortified calcium, bean, nuts, whole grain, and dairy products. Selenium and magnesium. Selenium is 70 to 80 microgram per day to reduce the GDM, preeclampsia, and preterm labor. Magnesium, the daily requirement is 350 to 400 milligram per day is recommended to improve the fetal growth and to prevent the preeclampsia. Vitamin A, it is 800 microgram per day is recommended, good for embryonic growth during the early pregnancy. So vitamin K, it is also very important in helping the blood clot formation. It is not needed during the pregnancy, except those on anti-seizure medication where there is a risk of vitamin K deficiency in the fetus. Oral vitamin K is 10 milligram per day from 36 weeks until the delivery. Now, metallozymes. The metallozymes, there is more than 300 enzymes. Those function can be impacted if the diet is deficient in manganese, zinc, magnesium, and copper. They play a very important role in preventing the maternal gestation health and ensuring good birth of the healthy offsprings, it prevent the GDM, it's prevent the toxemia in the pregnancy. So the take home message, the good nutrition during the pregnancy is a boon for mother and baby both. The macronutrition are the good source of energy. The micronutrients give the organ specific growth. The deficiency can lead to many issues like the pregnancy loss, birth defect, and metabolic disturbance. Supplement of such nutrition is recommended for proper baby growth. Maternal undernutrition and obesity increase the risk for the pregnancy complication and future health. So optimum amount of macro as well as micronutrients is very important. Westernization in the diet added to the risk of imbalance and deficiency and obesity epidemic. Mother health is equally important during the pregnancy as well as the lactation. So, my dear friends, with my folded hand, I just wanted to appeal you, please bless me with your precious vote for the chairperson, Sexual Health and STI Committee. So thank you so much for your patience listening. Thank you.
Would like to congratulate Apurva for such a wonderful talk and nice summing up of the about talking about the macro and micronutrients. It was a very nice reinforcement of whatever we have been doing since all these years. And all the best for the upcoming election. We are definitely winners.
Thank you so much, ma'am. Today is the second last day. Tomorrow is the last day of the voting. So whoever is yet to vote, please vote me in my favor so that I continue my mission. Yeah. Thank you so much. Over to you. Yeah.
Thank you, Dr. Apurva, for the wonderful lecture. Thank you, Samrina ma'am, as well as this one, Dr. Pratima ma'am, for your chairing the session. Yeah, Dr. Pratima ma'am. We now move on to the next session. Next one is another interesting talk. It's on baby-friendly hospital initiative. Our speaker for the session is Dr. Mangala Vani ma'am, and the chairpersons are Dr. Bharti Mishra ma'am and Dr. Indranil Datta. Can we have the slide, Abhishek? Yeah, Dr. Indranil Datta is a professor at Medical College, IQCT and Nursing Home at Durgapur, West Bengal. He is the immediate past president of Kalyani Obs-Gynae Society as well as the executive member of the YTP committee. He is also the East Zone coordinator of the Public Awareness Committee and IMA standing committee member for antimicrobial resistance. We welcome you, Dr. Indranil. Our next chairperson is Dr. Bharti Mishra ma'am. Dr. Bharti ma'am is a professor in the Department of Obs and Gynecology at MKCG Medical College at Berhampur, Odisha. Madam has been the past president of the Berhampur Obs-Gynae Society, ex-HOD also at the MKCG, MCH and PRM MCH. She is the life member of FOXY. She has various publications in national and international journals. We welcome you, Bharti ma'am. I would now request you to kindly introduce Dr. Mangala Vani ma'am and carry on with the session, please. Is Bharti ma'am? Bharti ma'am had joined.
No, I couldn't find Bharti ma'am. Bharti ma'am is there. Yeah.
Bharti ma'am has joined.
Yeah, Bharti ma'am was there.
Yeah.
I just saw her. Yeah.
Good evening, everybody. Hope you are not able to see me, but can listen to me.
Yes, ma'am. We can hear you, ma'am. Yes, ma'am.
Okay. It's not coming over. So, good evening, everybody. Very nice talk by my previous speaker, Dr. Apurva Kumar Dutt, and we wish you all the best for the next election. You are the perfect one to be chosen for that spot. Okay, Dr. Mangala Vani, MD DGO, FRCOG, an obstetric gynecologist and lactation consultant, director of Hirani Gynecological and Breastfeeding Medicine. Okay, that is there. So she is talking about BFHI. So consultant of group of hospital, past president of Breastfeeding Promotion Network of India, and that one. Recently, we have observed Breastfeeding Week throughout the country and in our hospital also. For 7 days, we, with all our staff nurses and sisters and everywhere, we celebrated it in different webinar and forum also. So she is the Indian Achievers Award for
thank you, Bharti madam. Thank you.
And all things, all the big biodata you can see. I don't want to between you and Mangalavani. So now over to Mangala, dear Mangala.
Thank you so much for the kind words. And first of all, I thank you, Foxy Public Awareness Committee, Rishikesh Pai sir, Madhuri Madam, and Priyankur and Monica. She's not here today. And respected chairpersons. Shall I share? Hi. I'll share my this thing.
Yeah, ma'am, please.
Can you see my slides?
Yes, ma'am. We are seeing white screen.
White
White
screen.
screen.
Yes, ma'am.
Yeah.
Why white screen?
Ma'am, just stop the share once. You have shared the white screen actually.
Okay.
Yes. Now again, share your slide, ma'am.
It's still coming as a whiteboard only.
Ma'am, on the
Ma'am,
bottom
have
side.
you
Yeah, Purva.
have you opened your PPTs in the
Yes.
background, ma'am?
Yeah.
On the bottom
Then
side,
you
there
can-
is a share screen button, green button. Click on that, ma'am.
Yeah.
Yeah, there are multiple windows, small windows.
No,
is
I
showing.
see only one window. That is whiteboard.
On the upper side, there is a button, basic. Click on that basic. On the below side of whiteboard.
Yeah, basic. Yes.
Yes, click on that basic.
Still, it is coming as a only whiteboard. It doesn't come like this normally.
Okay.
Um,
There is a below side of whiteboard. There are multiple small windows. It is not visible, ma'am.
no.
So the organizer can share now for her. You must be having the slides and PDF. PPT, you just share it from your side.
I will again stop sharing and let me see.
Ma'am, will you share your PPT in the group? Then Abhishek can share it from his end, ma'am.
I can email.
Yeah, ma'am. I am sharing my mail ID, ma'am, in the chat box. Ma'am.
Yeah.
Yes, ma'am. Do that, ma'am.
Actually, it doesn't happen like this. Why it has happened today?
Always it happens in webinar. It's a common thing. So
Yeah.
when I present, I give my presentation to the organizer. They share for me. I speak. That's easier.
Easier. Yes, ma'am.
Can
True.
you see now?
Ma'am, I have shared my mail ID in the chat box. Now it is a white screen only, ma'am.
White screen
White
only.
screen only.
Now,
Yeah.
can you see my slides?
No, ma'am. It's
No,
white
ma'am,
screen
it's
only.
white screen.
I have shared my mail ID in the chat box.
No, at loud.
Yeah.
You can mail it to me, ma'am. I will share on your behalf.
So have you shared?
In between you start speaking the introduction, they will be connecting.
Yes, ma'am.
Yeah, I will
Yes,
just-
Mangala, ma'am. You can start speaking. In the meanwhile, Abhishek will get to your slides.
No, I will email the presentation.
Yeah, ma'am.
Yes, ma'am. We'll take a second, ma'am. No problem.
I'm so sorry for this.
Absolutely fine, ma'am. We'll take a minute. No problem.
So we are discussing about breastfeeding. Actually, people have taken it granted that breastfeeding is like nectar. Okay, and we in our hospital make it compulsory that patient will sign it that breastfeeding they have understood, and copper tea or contraception they will understand at the first term of pregnancy itself. Try to motivate them. First term, second. Am I audible? Am I audible?
Absolutely, ma'am. Absolutely,
Yes,
ma'am.
ma'am. You are
Yes,
audible.
So first term, second term, third term, you take it, and those who are literate, most of them are literate nowadays. We tell them that in Google you see about breastfeeding, the advantage, the disadvantage. If you don't give, what is happening? If you give, what will be the benefit to you and the baby? And copper tea like that also, or Tibetomy like that. You motivate from the antenatal clinic itself. That the first and foremost things. And in my experience, what is the problem? After cesarean or after delivery in the nursing homes, the breastfeeding is less. The mother will tell, my daughter is not having feeding. They complain. So I make the mother out. I tell you are there, your baby is there. There is no food, what you take? You will automatically go to the mother and suck. If you give several food items, We choose one. If we will not give anything and the baby will be hungry, what the baby will take? Attachment, sucking will start, isn't it? So it is the effort of the obstetrician, pre-motivation before the lactation. Is it over now, Mangla? Are you okay?
Yeah, just another 30
My
seconds.
speaker, come on.
Another 30 seconds.
Because patient will come now. It's the clinic time. I have closed the door. And today we had a seminar. After finishing that, only we are coming.
So I have forwarded the email. Just check.
Yes, ma'am. I'm on that only. Till now it is not received.
Our hospital is also a BFHI hospital. We are having so many sisters, but we'll be wondering, when I go, I palpate some of the congested breast. When I go, I see that there is a lack of position. I made it by all the MSc nursing and BSc nursing students to put poster on the wall. How to sit, how the mother should be comfortable, how the baby should be comfortable, how they should suck like that, like that. But who is working nowadays? We have to make the staff nurses and the nursing students, and our student should be motivated to see that there's a proper breastfeeding is going on in every hospital.
Abhishek, have you received it?
Not yet, ma'am.
Even I have forgotten to write all the artificial that milk available. The name are also forgotten by me. Previously, we used to write small babies or anemic babies or weak mother. Sometimes we write the artificial feeding, other things. Nowadays forgotten because no writing, only motivating the patient from the beginning of the pregnancy to lactate, to give lactation.
Mangla ma'am, can you recheck my mail ID, please, ma'am? It's abhisheks@coronaremedies.com.
Yes.
Still, I have not received it. That's why, ma'am. I have checked my spam also.
So in the meantime, can you go for the introduction of the next speaker?
Can I just say hello to Dr. Bharti
I have saying now second time.
while we are waiting?
Pragya, when you have come, all of you are in darkness.
I have
Why
saying
you are
second
bright
time.
and white, you tell me. Why you are so bright and white? You make us darker. When you
Not really.
you put little blackish painting, otherwise you are looking all dark complexion.
Ma'am is glowing. Pragya ma'am is looking glowing.
Always. And today she is glowing more. So you make your light little fuse.
But to be very honest,
have
I
you
think I've lost my glow after COVID. The severe COVID that I had in 2020. I think after that I have lost my glow.
You have suffered. You have suffered from that. So your glow has little bit come back, but your whiteness is still persisting.
Thank you.
Abhishek, have you received?
I'm very fond of you, that you know. Pragya.
Yeah, of course. That's why I said while all this
Abhishek,
is
you have
happening,
to
I can just
unmute.
say,
And you have promised to come to Barampur, you have not yet come.
I know. I'll come, but
All presidents, they have come before being elected. Even Sunita came once to Barampur. It's my lucky place to be president of Foxy. All Foxy president. And few of them
Yes,
have come to my residence. I bring them, I give them tea, Nandita, Uncle Saria. And you know, Pushyam is my friend. Okay?
Hello,
Mangala?
Abhishek. Abhishek is not there. Have you received Abhishek?
No, ma'am. Still not received. Ma'am,
So
can
what we can do is you
ma'am, you
take the
just
next
share me your
question.
mail ID.
No,
Share me your
let
mail
us
ID.
send PPT to our group. From that
Yes.
group, you take
Send me one more email ID then, because twice I have sent about.
not in email. You send in PPT in the WhatsApp, and he'll be correcting that. It's also easy. I do like that. Whatever link you are sending on WhatsApp,
Ma'am, I am sharing my another mail ID.
Abhishek, you send a hi to ma'am, no? Just like you said. Send
Yes.
a hi from your mail to ma'am so that
Yes,
ma'am will
ma'am.
know it's you and she can accordingly send the thing.
Ma'am, can you share your mail ID, Mangala ma'am, in the chat
Vani-
box?
Yes.
oh, okay, the
And
organizer.
WhatsApp pe share karna would be easier. Will you be able to share on WhatsApp, ma'am? That would be
That's
easier,
I
I
told,
think.
no.
That will be PDF, na WhatsApp.
Hmm.
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 WhatsApp में भेजो.
Yes, ma'am. I am sending a test mail on this.
So nowadays onwards, whenever there's a webinar, all should share their PPT to this.
I think so. But it never has happened to me. This is the first
Okay,
time.
okay, it's okay. But so
It's
many
okay,
times
ma'am.
happens.
I think,
And-
do you want to take the next session first?
Yeah, that's
By
right.
the time we sort out
The
now,
next
you know,
speaker.
everybody's time is
Come
wasted.
on, come on. Next speaker should be introduced
Ma-
because time is short now. They will cut the webinar connection.
Ma'am,
Mangala
next
ma'am,
is the
I have
panel.
yes, ma'am.
Ah,
Mangala ma'am, I have shared my
And
test mail.
chairperson, next chairperson you introduce.
Ma'am, next is the panel. Our moderators are Supriya Jaiswal ma'am and Rekha Jha ma'am.
Let us finish their introduction.
Should we take that?
Huh?
Yes. Okay, ma'am. Okay. Okay, ma'am. Yes. So in the meanwhile, we'll proceed with the panel. Our panel for today is a case-based discussions on anemia, and our moderators for the panel are Dr. Rekha Jha ma'am and Dr. Supriya Jaiswal ma'am. Dr. Rekha Jha ma'am is, of course, the president of the Bhagalpur Obs-Gynae Society, also the East Zone coordinator for the Public Awareness Committee. She is the scientific chairperson of IMA Bhagalpur as well as has been the past secretary and vice president of IMA Bhagalpur. She is a live member of various societies like the Menopause Society and Red Cross. Welcome, Rekha Jha ma'am. Our next moderator is Dr. Supriya Jaiswal ma'am. Dr. Supriya Jaiswal ma'am is the vice president of the Patna Obs-Gynae Society, chairperson of the Adolescent Health Committee of FOXI, joint secretary of the Bihar and Jharkhand chapter of SOVSI, and the chief consultant at SM Hospital, Patna. Welcome, Supriya ma'am. Our expert panelist for the panel discussion is Dr. Pratibha Singh ma'am. Dr. Pratibha Singh is a consultant laparoscopic and gynecologist and IVF specialist, as well as the director of Healing Touch Hospital, Bhagalpur, chairperson of the IAEC FOXI 2020-25, as well as the current chairperson of the Fertility and Aging Committee of the IMS. Welcome, Pratibha ma'am. Yes, we have a gamut of panelists with us today. We have Dr. Nidhi, Dr. Devanjana, Dr. Sangeeta ma'am, Dr. Babita ma'am, Dr. Poonam ma'am, Dr. Kalyani ma'am, Dr. Rashmi, and Dr. Monica Agarwal ma'am. Abhishek, should I proceed with the panel or you have received the thing? Should I proceed with the panel then?
Yes, ma'am. Not received yet.
Okay, I'll proceed with the panel then in the meanwhile. Okay. So our first panelist is Dr. Nidhi. Dr. Nidhi is an infertility and IVF consultant at Nova Fertility in Patna. She has received the gold medal in Dr. Mahendra Narayan Memorial Gold Medal for being the university topper in 2010. And she has various publications and awards to her credit. Welcome, Dr. Nidhi. Our next panelist is Dr. Devanjana Datta Majumdar ma'am. Ma'am is the secretary of the Silchar Obs-Gynae Society and working as a consultant in the Women's Hospital, the oldest in Southern Assam. She has been the office bearer in various capacities in the local societies and taken part in various panel discussions. Welcome, Dr. Devanjana. Our next panelist is Dr. Sangeeta Thakur ma'am. Dr. Sangeeta ma'am is practicing as a consultant gynecologist in Isar Nursing Home. She's performed more than 10,000 plus surgeries, including one with the 5th cesarean section, and she's the secretary of the Saharsa Obs-Gynae Society. Welcome, Sangeeta ma'am. Our next panelist is Dr. Babita Shukla ma'am. Dr. Babita Shukla is the vice president of Gorakhpur Obs-Gynae Society, ex-secretary, treasurer, as well as the scientific secretary of the Gorakhpur Obs-Gynae Society, clinical secretary of the Isoparp Gorakhpur chapter, and she has been the organizing secretaries of various conferences. Welcome, Dr. Babita ma'am. Our next panelist is Dr. Poonam Sahai ma'am. She is the secretary of MOGS Gaya. She is a director of Vidya Maternity Eye and ENT Hospital at Gaya. and has been the organizing secretary of the 7th AOGS BJ Bihar and Jharkhand, and has been the life member of Red Cross and IMA. Welcome, Poonam ma'am. Our next panelist is Dr. Kalyani Singh ma'am. Ma'am is the associate professor at LBK MCH and the senior consultant obstetrician and gynecologist at SARSA. Welcome, Kalyani ma'am. Our next panelist is Dr. Rashmi Prasad ma'am. Ma'am is the chief consultant and director at Divya Vatsalya Mamta Fertility Center. She's treated more than 65,000 successful IVF couples. She is the recipient of the Icons Bihar Award and also has received Asia's Greatest Leaders Award by the Governor of Singapore. Welcome, Dr. Rashmi. And our final panelist for the day is Dr. Monica Agarwal ma'am. Ma'am is a director of Manokamna Hospital. She is a special interest in infertility, high-risk pregnancy and gynae laparoscopic surgery, and is one of the senior obstetrician and gynecologist at Shiliguri. Welcome, Monica ma'am. I would now request Supriya ma'am and Rekha ma'am to carry on with the panel, please.
Thank you, Dr. Satabdi. Thank you very much at the outset. A very good evening to all of you. Especially, I thank the Public Awareness Committee who has given me the opportunity to moderate this important panel on anemia, case-based discussion. And I also welcome, on behalf of my co-moderator, Dr. Rekha Jha madam, who already had been to USA and came back 2 days back and still in the jet lag, madam. From both of us side, we welcome all the panelists and we start with the panel discussion without wasting time. So, Dr. Satabdi, can I share my slide?
Yes, ma'am, please.
Yeah.
Yes, perfect.
Yes, ma'am. Yes.
Yeah. So, myself and Dr. Rekha Jha, who is the president of Bhagalpur OBGYN Society, and we are going to discuss management of anemia in pregnancy, a case-based approach. So let us start with the panel. We have, once again, I'll just name the panelists: Dr. Nidhi, Dr. Monica Agarwal, Dr. Debanjana, Dr. Sangeeta Thakur, Dr. Babita Shukla, Dr. Poonam Sahai, Dr. Rashmi Prasad, and Dr. Kalyani Singh. So many senior members and all of you, I welcome you to the panel. And also the expert, Dr. Pratibha. I think she is not there. So what we actually want to say, anemia is a vast subject. However, how much you discuss and whatever you do, it is so much difficult to cover all in a 45 minutes time. But still, we can keep on discussing things on anemia so that to gain more clarity and develop more skill to manage. Its prevalence across age and gender group has increased these days. Anemia has increased by 2 to 9% among children, pregnant women, and men, according to data shared in the National Family Health Survey 5, released on November 24, 2021. So to define anemia in pregnancy is defined as low hemoglobin concentration or decreased number of RBCs resulting in diminished oxygen carrying capacity of blood. How does WHO define? WHO define hemoglobin concentration of less than 11 gram per DL and a hematocrit of less than 33% is defined as anemia in pregnancy. CDC, that is Center for Disease Control, says that hemoglobin concentration of less than 11 gram per DL in first and third trimesters and less than 10.5 gram per DL during the second trimester of pregnancy is termed as anemia. So severity depends upon like mild anemia, 10 to 10.9 gram per DL, moderate and severe. Very severe is also seen, and everybody, I believe, must be encountering in day-to-day practice. So in worldwide, there's a huge burden of anemia globally. In India, In Southeastern Asian countries, 50% of global maternal death due to anemia and 80% of it occurs in India. So prevalence of anemia in India decreased marginally from 58% in NFHS 3 to 50% in NFHS 4 survey. So 58% of lactating females in India are anemic because they don't take proper diet. So starting from the first case, we have a primary patient referred to tertiary center at 14 weeks gestation with hemoglobin of 7%. So what is your approach for diagnosis? So this is an open discussion, and I think any of the panelists can take this question. Dr. Nidhi, are you there? Dr. Sangeeta Thakur?
Yes. Yes, I
Yeah,
am there.
yeah, madam, you can just elaborate on this.
She's primary 14-week gestation with hemoglobin less than 7 grams.
Yes.
Is, uh,
We are unable to hear you. Your net.
Internet. If I'm audible, can I take?
Unable to hear now.
Now it is
Now?
okay. Yes.
Now it is okay. Okay.
Yeah.
Okay. First of the history. See any breathing history, dietary intake history, and then physical examination. She adds the hemoglobin less than 7 grams. This is what is the size of the uterus or the pellet. See the
Yes. Your network is not okay, madam.
I think somebody else can speak out.
Ma'am, I can take up the question. Would you like me to?
Yes.
Yeah.
Whoever is possible. For whom?
Yeah, ma'am. Dr. Monica.
Possible, you can just.
Yeah, ma'am. So first of all, ma'am, we'd like to approach with the detailed history as to whether the patient was suffering from anemia right before the conception, whether she had any hemorrhoids, or about her dietary history, or anything else leading to anemia, like diet, any liver disease, any kidney disease, anything that is suggestive of anemia. Second, examination. We would like to see pallor, any pedal edema, we'll look for her tongue and any heart failure, or nails, condition of nails. We would see all these things. Then we'll go, splenomegaly, definitely. And then we would like to go for certain tests. The most suggestive tests are complete blood picture, peripheral blood smear, then other detailed investigations like liver function test, kidney function test, or we would like to go for her stool examination. So HPLC would also be done if there is any kind of suggestive of any hemoglobinopathies. So we would like to go for all these investigations.
Yes, very rightly said.
Yes.
See, first you whenever first approach for us is detailed history, we should go for, rightly you said, then go for the physical examination. Looking at her, we can discover, we can make out many points, and then the investigations. So in the history part, age, fever, chronic illness, threatened abortion, bleeding piles, menorrhagia, worm infestations, these all things we should know, we should ask her. Then the physical examination, as you said, pallor. Anemic person, you can directly see and tell most of the time.
Yes, ma'am.
7 grams. Yes, madam.
Just a minute. In the history part, we should also look at whether the patient is coming from some endemic area infested by malaria.
Certainly, ma'am. Certainly. Yes.
Patients having worm infestation, because these are in the guidelines of the government of India. So you should also be aware of the fact that maybe she has malaria.
Yes. Geographic predisposition, we have to see. Yeah.
Then, as you said, physical examination, pallor, color and shape of the nails, pale and bald tongue, jaundice, splenomegaly, and pedal edema. Then coming to the investigation, CBC, peripheral blood flow, these are the standard tests we should go for, and then we can diagnose the anemia. So, which are the two basic investigations which will help you to diagnose type of anemia? So
Complete
anyone?
blood picture and peripheral smear.
Yeah.
We'll look for the, yeah.
So what are the effects of anemia? So we know, okay, this patient is anemia, so anemic. So how do you say what are the effects of anemia? If she's anemic, what will happen to her? What can happen to her? In this case, at
Ma'am,
least.
we can divide the effects in three parts: antepartum, intrapartum, and postpartum.
Yes.
So antepartum, there can be because of oxygen deficiency, there can be abruptio placenta, there can be preeclampsia, there can be premature rupture of membranes, there can be preterm labor. So all these things, CHF can be there, infections can be there. Then during intrapartum, there are more chances of operative delivery. Again, CHF can be there. And yes, infections can be there. And in postpartum, there can be subinvolution of uterus, lactation failure can be there. And the patient can have infections. And yeah,
Yes.
that's it.
Anyone wants to add something to this?
And there can be on the baby because of the deficiency of anemia. Now the studies have shown that the baby will have cognitive defects because this iron is needed for the development of brain, for the formation of synapses and dendrites. So the deficiency of iron, particularly in the first trimester, will have long-term effect on the mental health of the baby. There could be increased risk of mental defects, autism, and cerebral palsy and cognitive defects, and there will be poor performance in studies later on. These are the recent studies of the long.
And mother feels weak, fatigue, and breathlessness, dyspnea.
Yes.
Sweating, palpitations.
Dr.
within
Rashmi,
a
you
week.
want to add on?
Fatigue.
Yes.
Respirate fast.
So anemia increases both
both maternal and fetal.
Yes.
I would like to add something.
Yeah.
Yeah.
Yes, madam. Tell it.
Yeah. Regarding the type of anemia, why not to do the HB electrophoresis and the serum iron profile also?
Yes, ma'am.
Huh?
Yes.
I told that. Yes, ma'am.
Yeah.
Definitely, yes.
HB
I told that.
electrophoresis and the serum iron profile.
Yes.
Besides the CBC.
HPLC has to be done. Yeah.
Yeah. Okay.
So here, as all of you know, that it will affect mother and fetus both, and then antepartum, rightly said, antepartum, intrapartum, and postpartum. So antepartum, you can face PROM, preterm labor, preeclampsia, abruptio, recurrent infections, and congestive cardiac failure. So during intrapartum period, prolonged labor, because she'll be so exhausted, she's so anemic, increased operative vaginal delivery can happen. Then congestive cardiac failure, as you said, increased cesarean delivery because of these anemic patients. Postpartum, usually you will come to see mostly those people who are anemic, they will have more of PPH. Then puerperal sepsis is also very common in them. Subinvolution of uterus, failed lactation, anemic patient. You should counsel your patient for taking good iron and keeping their hemoglobin up to mark so that the lactation part also is not affected. These things actually really affect the counseling part. If you tell the patient that she will face such problems during the postpartum period, I believe many of the mothers will try to improve on their nutrition and everything. So postpartum depression is also one of the most common, very, very common due to this anemia.
Anemic
So the fetal complication, as Dr. Kalyani, madam, you rightly said, fetal distress is there. Usually you will see they will have small for gestational age babies. Low birth weight is very common to see in anemic patients. Then prematurity, IUDs. I had a patient who was very close to me, and then I used to be after her for her because she was facing low hemoglobin, but then she didn't care and she faced IUD. That was a very nightmare for me actually. So in anemia can really turn up into such difficult situations that you won't be able to explain later. Then neonatal infections and neonatal anemia. Then what are the symptoms of anemia? I would like to ask you, Dr. Rashmi.
Yeah, most common is the weakness, giddiness, like symptoms patient used to face some cramps, breathlessness. These are the initial symptoms.
Fetal edema.
Actually, you know, these are the very, very common things, and every day in Bihar, Patna, or in rural areas, we often come to see. And when patients they'll walk and come, they'll be breathless. And you can just, looking at their face, you can make out, yes, she is an anemic patient. Isn't it? I think many of you must be facing same thing every day. Isn't it? I ask all the panelists, your experience.
Yes, ma'am.
Very common, very common.
Very common. Yeah.
And the signs, as what are the signs, like pallor, color of this bulb, pale bulb tongue, jaundice?
Pale
These are
bulb
the
tongue, pallor.
Now,
fatigue.
So
we can get hepatosplenomegaly, especially in malaria and if the anemia is due to that, and hemolytic anemias also. And in severe anemia, we can get functional systolic murmur.
Yes.
Okay.
So you know what? We should also put a stethoscope on these people, these patients. We usually don't try to do that usually, but in anemic patient, if you really put, you will find something or the other for sure, isn't it?
Yes.
Then I'll take from all the panelists what dietary advice you will give to your patient in this particular patient who is already diagnosed with 7 grams of hemoglobin. So, Dr. Kalyani,
diet
madam,
is not going to.
No, matlab, at least something you are going to tell, no?
Only diet. Only
No,
diet
will not suffice.
No,
Only
it will not
diet at 7
suffice.
grams?
But you will just dietary counseling. I want to know. Later on, we'll talk on the other.
Dates,
Green leafy
apples,
vegetables.
Am I audible, ma'am?
Green leafy vegetables.
dates, apples.
Mostly green leafy vegetables. Protein.
Beetroot, carrot, jaggery, brown sugar,
Sprouting,
and
pomegranates,
fermented foods, beans. All these things have to be included in diet.
Yes. And do you think they listen to us many a times? What we will
they avoid.
They avoid. They will not listen to you.
You used to say the banana causes me cold and cough, and
Yes,
I don't think you used to take banana and this papaya. All explanation is there.
Yes, they will give you many excuses of not being able to take, not being able to digest, so many things. So now, so what line of treatment other than dietary? So what all you will, each panelist can share their experience. What will you do to treat this case?
At first, we advise the correct food, and after iron supplement, it advised. But at the as you said that the hemoglobin level is 7 gram or normal. What is your question?
Yes, it
14 weeks,
patient
7
how 14 weeks, and
14 weeks.
Yeah.
So oral iron tablets should be prescribed along with the vitamin protein and good diet.
Do you think
think
deworming is important?
Deworming is very important. Yes. In our
The patient-
scenario, deworming is important.
The patient is 14 weeks already.
Yes.
She is severely anemic and 14 weeks. You have to keep in mind that. And dietary advice you have to give, but you have to consider other things. So, will you only give oral iron, or would you like iron?
I would prefer to go with injectable iron because the longer she is anemic, the more complications can be there during the pregnancy. So it would be better that we fulfill her iron stores and make her at least reach 10 grams. Yeah. So preferable would be injectable iron.
So injectable iron, oral iron for maintenance, and then
for maintenance oral iron.
If needed, then you will give a blood transfusion and what
Then
else?
in third trimester, ma'am. Not now.
but she is 7 gram. If she has some problems in the heart, if she is
Yes,
having
ma'am. Yes, ma'am.
asthma,
Then only. Yes.
it might be necessary at times that you have to give a PT. So you have to consider all the things,
Yes.
like just to take her out of that critical situation, so that because the second trimester also the growing fetus is growing very fast, and
Yes,
it will feed all the things. So maybe your IV iron is not catering to it. Maybe the patient will not return back for IV iron. So you have to at times consider, and together with the advice of the physician or the cardiologist, you have to consider a blood transfusion as well. So next of the things you can discuss.
And what is the WHO recommendation for oral iron?
So, ma'am, as per WHO, for prophylaxis, we give around 30 to 16 milligram of oral iron along with 400 microgram of folic acid. It is continued throughout pregnancy and for 3 months postpartum. As per Government of India, we give 60 milligram of elemental iron with 500 microgram folic acid throughout pregnancy and continued till 6 months postpartum. But if the patient is anemic, the dose is increased. We give 2 tablets, that is 120 milligram of elemental iron with 400 microgram folic acid. And then we do deworming with 400 milligram albendazole in the second trimester.
Ma'am, I want to interrupt.
Yeah,
There is one thing, there is one thought that just by increasing the dose of iron, you can't increase the absorption of iron. If you increase the dose too much, that rather hampers. Like if you give 60 milligram of elemental iron in the morning, then again you give 60 milligram of elemental iron in the evening. So a maximum part of that second dose is not absorbed. So rather than increasing the dose, you should maintain the regularity of the iron. It's always better to give single
let me
dose,
say
regular
something.
days.
Let me
The
add
absorption
something.
is more.
Regarding
You
the
give 120, it won't be absorbed as much as we
let me say
expect it
something.
to be. Because
Regarding
there
the
is a
increasing
substance
dose,
called
it
hepcidin, which is
not
increased
increase
when you give
beyond
iron.
160 milligrams.
So no
But
use
till
of
up to
giving iron
120 we
twice
can
daily.
increase.
That is my
Beyond
objection.
no. The
No,
increase
Dr.
means
Babika
you
was just
cannot.
telling was about the guidelines. You have to listen. He was
Yeah,
speaking
that is,
about the
yes, ma'am.
guidelines.
That
It
is
is
in the
Matt's
guidelines.
personal opinion that it should be not increased because the absorption is not going on. So on the totality, you have to look at the patient, what are the guidelines, and even there is a guideline of Government of India that at least 100 days.
Hello, can you just unmute the other speakers? Those who are not in panel,
noise.
please unmute them.
Ma'am,
The technical
regarding the increasing in dose, we should not
Yes, ma'am.
increase beyond 160 milligram, but 120 is not bad. And then now there is a recent study that the hepcidin levels are, once you give the iron, then the hepcidin levels start increasing and iron absorption decreases. So we can give
Yes,
an
ma'am.
alternate day that also
Yes,
gives
ma'am.
good results.
Yes, ma'am. My point. Exactly. Yes, ma'am.
So, see, many a times, depending upon the patient's condition, your patient, your choice of we treat by choice also. Sometimes guidelines we do follow, but many a times patient to patient things vary a lot. Some people, they are unable to digest the oral iron. So there you have to, even though we need not give to other patient, but in some patient who are not tolerating oral, we go to the injectable forms. So
Yes,
it's not the guidelines can guide you or rule you. You have to deviate a little bit and you treat your patient according to your follow-up, how she is responding to your treatment. So we have to be a little bit open, not strictly follow the guidelines. We can increase the dose sometimes when she is well tolerated. And if it is, if she is having belching and so many of problems, then we can have regularity is always very good. So we should better maintain that. So now, which iron preparation you prefer to give mostly? So everybody has that this answer. Now tell me, Rekha, you start with your experience.
I think ferrous fumarate is works well for me, and yes, in the among the injectables, I have tried everything, and it all depends upon what type of the patient is. More on the type of the patient, though. Yes, in the injectables, FCM is the best, but of course, due to the certain considerations, you have to give iron dextran also, iron sucrose also. So everything works. It has to be according to the tailor made. So according to the cost and also where the patient is going to get that IV iron. That is also important.
Dr.
So,
Monica?
Same, ma'am. I completely agree with Dr. Rekha, ma'am. Same.
Okay. So anyone wants to say, add on anything?
Ma'am, if we are regarding the absorption part, we see that we have so many preparations, the efficacy is almost same. But then if we see regarding the tolerability part, we see the ferric preparations, they are bacteria friendly and even the ferrous bisglycinate. But then the disadvantage is being that the bioavailability of such preparations is less. So we customize it according to the patient. If the patient is able to tolerate it, we can give ferrous ascorbate fumarate. But if patient is not able to tolerate it, we can give the ferric preparation or we can give the so there the absorption is the GI side effects are less, but the patient tolerates it better. But one thing we should keep in mind, we should not give the entry coated or sustained release preparations because they're not very efficacious. And
The
regarding
most important thing is that when we give the iron preparation orally, we have to tell the patient how to take it. Most of the
Yes, that
time,
is
the
very important.
Indian population is in the habit of taking tea along with their meals. And that is the biggest thing that hampers the iron absorption. We are giving iron, we are increasing the dose, but simultaneously patient is increasing the tea intake also. So that is the main part. We have to tell them how to take it.
She should take the iron preparation either
Yes,
with
ma'am.
empty, if she is able to tolerate
With
it.
the
But
with
if
meals
not
is
able to
most
tolerate
tolerable.
it,
Yeah,
she
ma'am.
will take it 1 hour after the meals. And the
Yes,
things
ma'am.
to be avoided when she takes this preparation, she should not take tea, coffee, milk, calcium, some drugs like tetracycline. She can take it with foods which are rich in vitamin C, like orange juice or like. So
Yes,
this increases the absorption.
Increase
So, and moreover, what we see is this hepcidin level, when they are low, iron absorption is maximum. And studies
Yes,
have
ma'am.
shown that the hepcidin levels are lowest in the morning. So if we give this iron preparations in the morning meals, then the absorption is better.
Yes. So this also, as I said, okay, we try and do best for your patient, but certain guidelines we have to follow always. So how will you calculate the parental iron dose?
That's a very simple formula.
So, ma'am, we follow the Ganzoni's formula.
Yes.
So the body weight into the hemoglobin deficit, that is pre-pregnancy body weight, into 2.4 plus 1000 milligram per stores, or you take a 10 to 15 milligram per kg body weight.
Yeah, ma'am.
Yes.
This way we
So
calculate.
what are the indications and contraindications for the parenteral iron therapy? As we know, just for revision, let us of anyone speak out.
Anyone having hypersensitivity. Secondly, any kidney disease, any liver cirrhosis, any kind of hemochromatosis. So if any of these is there, any kind of breathing trouble or any such symptom is there right from the beginning, then we prefer not to give for
Or
go
even
for
for
oral
that
iron.
matter, kidney disease,
not to go for
that is
injectable iron.
untreated pyelonephritis. There also you don't give.
Yes, hello.
And
Kidney disease mein ma'am aa gaya. Any kind of clearance is there not there, na? Yeah, ma'am.
Yes,
This is the list of contraindications. But
yes, ma'am.
These are the contraindications. So the indications would be
when should
the
you
patient is not able to tolerate oral iron.
Yes.
Patient is not responding to oral iron therapy. Patient will got a rapid rise in hemoglobin levels. And patient is severe anemia, you want to give blood transfusion, but patient is not ready or the blood is not available, then you can try with injectable iron also.
Correct,
and those patients with renal disease along with erythropoietin and patient is anemic, we do add injectable iron.
Exactly. Injectable iron, so we in case of kidney disease, so we go for erythropoietin injection along with the blood transfusion. We hardly go for iron
you can give injectable iron also. And at times also,
Can,
in
yes,
patients
ma'am, but
with
we prefer to go
cancer
for blood
patients,
transfusion in that
where
case.
chemotherapy is
Monica
being
and Dr.
given, then you
Babita.
give it along with erythropoietin.
Erythropoietin, yes.
Monica and Dr. Babita, you are all speaking very rightfully what you should do. What are the implications? But the main important, practically, we get patients who are approaching the EDD, and then we have to think, oh, we have to maintain the iron level. So then you jump in for IV iron most of the times. Because if there is a long period,
especially in the early trimester, like 32 weeks, 34 weeks, when we are getting anemia, we don't have time to give
and
injectable.
you have to give IV iron. And another thing is there that in some cases, where you think that even after giving oral iron, that no absorption is going on, so you have to give IV iron in those cases. And not only about are these indications for giving iron. You have already discussed the contraindications. Anything important, any other important indication for giving IV iron? Is there any other indication? You have discussed 2 or 3 things, like just tell me that what is the level of hemoglobin which indicates that now you have to give IV iron. That you
severe anemia, ma'am. In
No,
case
no,
of
no.
severe anemia.
When will you give? Is it 9 gram and you will start IV iron, or is it
No,
7,
no, no.
5 or
7,
8?
ma'am.
So the level should be 8 or below 8.
Less, yeah, ma'am.
7 to 9 grams.
All are doing that. If it is seen below 8, then you go for IV iron.
Yes.
Okay,
So the side effects, yes, Rekha madam, the
Yes.
side effects of parenteral iron therapy, as everybody knows. So we have to straight
No,
away.
everybody knows, but we have to just ask the panelist. So anybody
ma'am.
can volunteer.
So-
Where is Dr. Nidhi? I have seen her on the screen, but I don't think she has spoken. Dr. Nidhi, are you ready to answer?
Yes, ma'am.
Yes. What are the effects of parenteral iron therapy?
When the patients are given parenteral iron, they usually might complain of mild headache, mild chest pain, or mild signs and symptoms of increased congestion. Like they may complain कि बहुत गर्मी लग रही है, flushing हो रहा है, kind of these. Some patients may even complain of mild pelvic pain or abdomen pain. And very commonly that I see is almost 50% patients, they complain of nausea and vomiting. Apart from that, if parenteral iron shows an allergic type of reaction, then the patient may have signs and symptoms of allergy like spasm, urticaria, and sometimes breathlessness as well.
So these are the listed side effects of IV iron. And since these things can happen, so it should be given under supervision, some sort of supervision. Otherwise, unsupervised IV iron is not good. So what are the advantages of different types of like injectable iron? Anybody can answer.
Ma'am, am I audible?
Yes.
Dr. Devanjana here.
Yes.
Am I audible, ma'am?
Yes, ma'am.
Yeah, iron sucrose, it is easily available, cheap. As for carboxymaltose, ferrous carboxymaltose, it can be used in high doses and also allows rapid administration. Also, a single dose of around 1000 mg diluted in 250 ml NS can be given over 15 minutes. Then it doesn't cross-react with the dextran antibodies, so test dose isn't required. Serum ferritin levels return to normal in about 3 weeks, and as also it has less toxicity compared to other iron preparations.
So this is a comparative thing shown that iron sucrose has these advantages and iron carboxymaltose has these advantages. So most of us, in most of the cases, go for the cheap version, But if the patient is really requires infusion in a short period of time, then you go for carboxymaltose, or the patient affords, or the patient can stay back then. So in the rural settings, the first one is better, and in the urban settings, the second one is better. But of course, in the iron sucrose, since there can be more of reaction, a test dose is required. So the first time when you infuse, it should be strictly under supervision in a nursing home or in a clinic. And in the second one, you can allow, okay, go to the periphery in the PHC or somewhere you can take it. So these are the patterns on which we are practically working every day. So what are the indications of erythropoietin injection? Yeah, you want to ask, Madam Kalyanidhi, you want to?
Yeah, it can be, it should be given in chronic kidney disease, grade 3, 4, and 5. Erythropoietin is produced by the paracortical cells of the kidney, and it is directly sensitive to the SpO2 level. So SpO2 level is low, then erythropoietin will be produced more, and it will send signal to the bone marrow to produce more and more RBC. So only in chronic CKD 3 and 5 it is given, or in also in cases of chemotherapy induced anemia.
Yes.
Also antiviral.
Yeah, antiviral therapy.
Fludarabine is given anemia because of
antiviral therapy also.
And so, as we discussed earlier also, what are the indications of blood transfusion? Little bit of it has been discussed, and anyone can take up this question. What are the indications directly? Usually we avoid blood transfusion, but what are the real indications that we need to transfuse blood?
When first of all, there is no time for oral or injectable iron to act.
Yes.
So we are nearing
Then
term.
severe
Then
anemia
we don't have
in
any
all
other
stages
option.
of pregnancy, ma'am. And
Yes.
if the patient ma'am,
is
severe
symptomatic
anemia.
in less than 7 grams, with the
less than 5 grams in any stage of pregnancy.
Yeah.
5 to 7 grams,
in
suppose
third
it is
trimester.
below 32 weeks, and the patient is having severe symptoms like some cardiac symptoms, or there is ongoing bleeding, or there is hemodynamic instability, then we have to give blood transfusion. After 36 weeks, like even if in the absence of these symptoms, we do give blood transfusion in these patients. But after, if the patient is in labor and she is anemic, we would like to give blood transfusion. Here we cannot give oral and injectable iron.
Yes.
Or if patient is having hemorrhage, like antepartum, postpartum hemorrhage, so we have to give blood transfusion there also.
Even
So
in
there-
iatrogenic causes,
So there are two
LSCS tears, etc.
So there are two things. One is where hemorrhage is occurring, and one is where anemia is, it is a chronic anemia.
Severe.
These are the two categories. So in one, you have to think that the delivery date is approaching, acute necessity, or maybe there will be an intrauterine death. In those cases, if it is severe anemia, you have to give blood transfusion. And in the cases of hemorrhage, there is no other answer than the blood transfusions. So you have to give blood transfusion. But one thing you have to see, that in cases of chronic anemia, or in cases of anemia existing for a long time, you have to transfuse packed cells. And in the case of hemorrhage, you can transfuse whole blood. So these are the things.
It's always better to transfuse packed cells when we are not
It's always
expecting any
better.
kind of
That
hemorrhage,
is
because
true.
there are chances
That
of
is
CHF being aggravated. Yeah.
because
So either we give it with Lasix or under physician supervision. We have to be very careful while transfusing blood in a severely anemic female. Yeah. So it's
But
always
that
better
is
to
true,
go for
but
packed cells.
Dr. Monica, everybody is not working in that setup. Plus,
Exactly, ma'am. Exactly.
like many places, they're not having component. So you have to just think what you have to do.
Then we have to omit the upper wala part, jo blood
Yes,
blood kaake chhod diya.
That is why I said packed cell, because you just
we
have to
omit
omit
the
the
serum.
serum part. But
Yes, ma'am.
always, if you don't give the serum part, it is better, because then less amount of reactions are going to occur. So
Yes,
that
ma'am.
is the main thing. And sometimes some physicians, they prefer giving it because they think that there are some you need some factors which is present in the serum.
Yes, ma'am. There is a dictum now. Now you have to give like when you give packed cells, you have to give plus platelets. You have to give serum in a certain ratio. That is there. But still, we want to transfuse only packed cell when it comes to us. Where we want to place it.
With packed cell, you are at more peace. You are at
Yes,
more
ma'am. Yes, ma'am.
And what are the precautions we will take in conducting delivery of an anemic patient? Dr.
Cut short,
Kalyani
second
madam.
stage. Yeah.
Kalyani madam, आप बताइए.
We will avoid the blood loss. We will go for the minimum blood loss.
Yes,
and we won't overload the patient with fluid, either crystalloids or the colloids. So there should be oxygen supplementation, or we do the continuous monitoring with the monitor, and cut short second stage of labor by vacuum or forceps depends upon the gravity of the patient. If the patient is primary, then we may go for the vacuum or forceps. But if the patient is multi, she will deliver automatically more easily. And we should give methylgene. Yeah, blood should be ready. And if we have to give the Lasix, we will keep Lasix ready. And also, I will suggest one more thing. If the patient is chronically anemic, then we should have a chest X-ray. It is better because so many times the patient is having cardiomegaly, big heart. So in that case, we have to be very careful. If it is a patient of chronic anemia, we should think of a chest X-ray also, because I have seen the cases of cardiomegaly.
Yes, Dr. Monica, you wanted to say something?
Chest X-ray in pregnancy bit tricky.
But it is a case
bit
of chronic
tricky.
anemia.
Yeah.
Seen cases. I got this chest X-ray done. It was
Ma'am, better to refer the patient to physician once and get an opinion. Why to pay in all?
No, we will send the physician if she is having some breathlessness. If it is a case like if she is having breathlessness, it means she is having.
Correct, ma'am. But in that case, better to have a physician reference.
In cases of chronic anemia, I am just stressing, you should think of cardiomegaly also without any other.
Ma'am, ECG करा सकते हैं, echo करा सकते हैं. That would be better, I think, and that comes under pre-op investigations. Anyway, we get it done.
हम लोग जल्दी फिजिशियन को रेफर करते नहीं है. बात तो ये भी है. सीधे आती है.
We should take as much help as possible in managing such cases. It's always better to be safe rather than to be
but in
risky situation.
Patient comes directly.
Yes, Kalyani ma'am is right, because
there should be a good team, ma'am.
It's very difficult to make a good team in the periphery. Whom you will
ma'am,
have?
husband hona chahiye physician.
So those are not the criteria to manage a case of anemia now.
Pediatrician भी बहुत helpful होते हैं, surgeon भी होते हैं.
Pediatrician, anesthetic सब मतलब
physician पे एकदम focus नहीं कर सकते.
husband और कई boyfriends चाहिए.
नहीं. See, just to interrupt, I will tell you. See, Manyata training going on, no, or otherwise safe motherhood, everywhere you will see call for help. We cannot manage a severe patient, serious patient, all
for help. Yes, ma'am.
So we have to have a team.
I will tell you a story.
Okay.
I will tell you a story.
Tell me.
Yes, ma'am.
I was not, so I didn't mean to interrupt you, Supriya.
Yeah.
Just on this case that madam said that you should get a chest X-ray for cardiomegaly. There was a case with severe anemia and she suddenly went into labor and she was delivering, and because of the labor pains, it seemed that she was very dyspneic, and a physician in the periphery said that she's having congestive cardiac failure just at looking at her. There was no cardiac failure, it was just labor, and as the baby was delivered, everything was fine. So there are so many deceptions and so many things in the periphery that you just cannot say. So in all the setups, it is different, and chest X-ray with guard can be done in cases in places where the echo is not available or something. But if any sort of you have like any indication that there may be a heart failure or something, then you should just investigate somehow or the other. So everybody is right, like Kalyani madam in her setup is right, and Monica in her setup is right, that yes, of course, we should delegate the things to the physician. So now let us proceed, Supriya.
Yes, yes.
Continuous.
Over to you, madam. Rekha madam, you start with this
So
case.
case 2, the primary patient referred to a tertiary center at 32 weeks gestation with a hemoglobin of 7 gram, no improvement after 2 courses of parenteral iron therapy. We have, I think, already discussed this, but again, Dr. Nidhi or Dr. Devanjana.
Ma'am, the investigations will go for serum ferritin, and maybe we'll go for iron studies, electrophoresis, reticulocyst counts, and peripheral smear is very important in the context that we can look for all those sickle cell anemia, spherocytosis, abnormal cells, malaria, those things we can do in a peripheral smear.
And history is also very important.
History is always important.
Yeah.
Yeah.
Also, folate and B12 assay, because sometimes they coexist with iron deficiency anemia. We do not get response.
Yeah.
But before giving iron, parental iron, they must have done an iron study, ma'am. They can't, they mustn't have given like that only, no?
So, should we proceed to the treatment, or anybody wants to speak out anything more? Does anybody want to add something to this? Like this was the case. She comes at a tertiary center at 32 weeks with hemoglobin of 7 gram, no improvement after 2 courses of parenteral iron. And you said that serum ferritin, iron studies, reticulocyte count, and electrophoresis, peripheral smear for malaria, all this has been done. So what will be the treatment?
Blood transfusion. Blood transfusion has to be given.
Can I speak one line, please? Who is when any female patient comes with 7 gram, one has to do a thorough clinical examination. Don't forget to see this sternal tenderness. Don't forget to do this splenomegaly and hepatomegaly. Don't forget to see for anemia. And all history you have told, I have listened everything you have told. But nowadays people are missing the clinical. They're only depending on the investigations. And we do HPLC for less than 7, peripheral count smear for everybody, and the total morphology, and take the history. Already you have mentioned. And don't try to forget the clinical finding, because 7 gram is severe, and you have to also look for leukemia, peripheral smear count, and other things what you have told. So splenomegaly, malaria, and every patient, pregnant patient, especially in our place, in a remote area, one has to do for MP-ICT what you have told. Long, big spleen and liver, they are coming with chronic anemia. 3 gram, 4 gram patients are coming. So that should not be in India. And we are all slogan is that anemia mukt Bharat. So now proceed. Thank you.
No, if the patient is resistant to the iron therapy, then we must rule out the other forms of anemia, like thalassemia or the sickle cell anemia, and the iron overload also. If there is iron, this iron profile is a must, because if there is no iron deficiency anemia, then we will have to treat her very carefully, because we can't overload her again with iron. Although the blood transfusion is mandatory, blood transfusion is must.
Yes, ma'am.
So, iron load always you have to see if you're suspecting thalassemia and also sickle cell, because that will determine the ferritin level, will guide you whether it's a really iron deficiency anemia or it is due to some other things. And we are doing HPLC also. So when sickle you and thalassemia, you have to decide whether you are loading or not loading. But most of the patient in pregnancy is a dimorphic anemia, iron deficiency and maturity, folic acid deficiency. And most of them are nutritional. Till then, severe anemia below 7 and 8, one has to do all investigation peripheral count, sickling, ruling, everything, then you try your treatment. As Madam has told, we cannot load the patient with a lot of iron only. It is detrimental for the patient. And in few cases, you are seeing the type of anemia by the size, MCSC and microcytic or not, what is the volume, that also you have to see.
So, ma'am, before starting parenteral iron, we should always do a serum ferritin and rule out, no?
Exactly, ma'am.
So why 2 courses were given without doing all these things?
Serum ferritin is costly. Is it available in all hospitals? So serum ferritin is done in certain case. Iron injection by government and by WHO is given because it's mostly it is not symptomatic or anything. Most of them you take as nutritional, 9 gram, 8 gram or like that, depending on the gestational period. Iron is safely now given in peripheral hospital and hospital along with a WHO protocol, along with the deworming agent. So clinically you have to evaluate severe degree anemia and do the investigation. Even without serum iron, you can also give iron injection. What I think. So, but it's up to you.
The patient has come from a smaller place to a bigger place. This IV iron has already been tried and 2 courses has been given and still there is no response. Then she comes to the tertiary care center and there these studies are done so as to determine actually what is the root cause and now what how we should proceed. So just in the initially you give a blood transfusion, then study the patient whether it is a hemoglobinopathy or not, and then proceed. So that was it.
So we have another 10 minutes left. So Rekha madam, about the ANC counseling, just ask.
ANC counseling, yes. So what is the counseling that should be done in the first, second and third trimesters? Is it about the same patient?
Sorry, ma'am.
So general or same, you can just ask all the panelists.
General counseling we're talking about. So what will be the counseling during the ANC period?
Ma'am, first of all, the dietary advice has to be given.
No. If it is, we are asking ANC counseling in these patients. If the patient is found to have thalassemia or hemoglobinopathies, what has to be?
The husband has to be investigated, ma'am. The husband has to be investigated, and amniocentesis and genetic testing,
major or minor.
they can be referred for all those. Prophylactic
Major or
folic
minor.
acid, 1 milligram, and maybe thromboprophylaxis in case of hemoglobinopathies.
So
Since
since
hemoglobinopathy.
to have thalassemia or a hemoglobinopathy, you have to go to see whether it is a thalassemia major or a thalassemia
Major or minor.
or whether it is
Minor.
sickle cell anemia or something, some other type of hemoglobinopathy. And so amniosynthesis and genetic testing should be also offered because to know the full status of the patient and the baby. And the prophylactic folic acid should be given and penicillin prophylaxis and thromboprophylaxis in the case of hemoglobinopathies so that the patient is steered clear from these coagulation problems. So next.
Ma'am, one interruption. Ma'am, if it is found to be thalassemia major, why would we ask the patient to continue with the pregnancy? We would always like to diagnose the thalassemia major in first trimester of pregnancy by doing the HPLC, and we would like the patient to abort the child. Why would she carry such a child who is not going to live long?
According to the question, the patient has arrived at 32 weeks.
Yeah, 32 weeks, ma'am, we don't have any other option except for the, ma'am.
That is it.
So, but nowadays we all do HPLC in the first
We are
trimester.
unaware of hemoglobinopathies not only in the periphery, but in the medical colleges also. In our medical college at Bhagalpur, there is still no electrophoresis. So patients are not actually, we don't know the status of the patient and whether hemoglobinopathy is there or not. So that is.
A thalassemia major patient will have dealt with lot of things before reaching 32 weeks of pregnancy.
Yeah, that is true, but still
not be unknown to her. So we have to assume that she doesn't know that it's a thalassemia. Thalassemia major will have to deal with many things before reaching 32 weeks pregnancy.
Yeah, very difficult.
It's impossible that she'll reach 32 weeks without knowing that she's
Correct. Yeah.
So now coming to the case 3, Rekha madam, you can continue.
Which of the following is a possible cause of anemia in chronic kidney disease patients in pregnancy?
No erythropoietin.
In
Yes. This is the main reason behind
No
this.
erythropoietin. Yeah.
So that is why injectable is given in these cases.
Yes,
so
ma'am.
How renal diseases cause anemia?
What is the process? How it when kidney there's disease in the kidney, how does it cause anemia? So this is also a very important thing. So whatever you give to them, they don't improve. So why?
Erythropoietin injection has to be supplemented along with.
There are so many reasons. So this is a form normocytic normochromic anemia. The erythropoietin is synthesized less in amount because due to the kidney damage. In normal patients, the erythropoietin level in cases of anemia is 10 to 100 times higher than the in cases of kidney disease. So there is a less absorptions from the gut, and also there is there might be some bleeding from the during dialysis, or maybe some and there may be dietary deficiency, and also there is a role of inflammation. All these factors, they lead to the anemia in the case of the chronic renal disease.
Yes. Anything more to add by any panelist?
Nothing.
Nothing.
There is increased hepcidin level in cases of the chronic, because this hepcidin is not neutralized by the kidney. So this increased level also hampers with the iron absorptions, and so there is anemia, chronic anemia. There is anemia in the chronic kidney disease. Hepcidin level also, increased hepcidin level.
Now, how do you treat this patient?
Erythropoietin injection along with the blood transfusion.
Or the erythropoietin. Yes.
Injectable iron, ma'am.
Yeah.
Erythropoietin along with injectable iron.
Also blood
Might be in blood transfusion.
Blood transfusion.
Yes.
Yeah.
Blood transfusion is always there.
Yeah.
At 32 weeks, we would rather go for blood transfusion along with the erythropoietin injection. Yeah.
So this is the last case. ANC patient came with anemia and MCV is 100. And how will you manage this case? Just anyone can take up this last case. First of all, how will you diagnose and manage? Overall view, just give. Starting from Dr. Monica, you start.
Complete blood picture and CBC has to be done. So as to get an idea whether it's already seen that this is going to be megaloblastic anemia. So accordingly, we'll supplement.
So we'll find out the type of, it could be due to B12 deficiency, folate deficiency, or other causes. So we do serum B12 and folate levels. If they are low, then you will supplement that. But sometimes you get it in a borderline, the B12 and folate, and then we are in a dilemma. So I don't know whether how much these tests are available, but then you do the homocysteine and the methyl malonic acid levels. If both of them are raised, then it is B12. And if only homocysteine is raised, then it is folate deficiency. So accordingly, we can supplement. So we give, if it is deficiency, we give injection B12 1000 microgram in deep intramuscular or subcutaneous. We give it weekly, then for 1 month. And then we give it monthly till it is normal. And then we follow up these patients by CBC and B12 levels, seeing that they come to normal. And folic acid, we supplement it orally, tablet of 1 milligram or 5 milligram per day.
Yes.
And in all cases, deworming side by side is always very important.
Yes, that is important.
Yes, because once, like why we refer our patients to the physicians? Because we don't bother to see many things that we can also do. So
Yes.
in periphery, we are handicapped. We don't have much people to refer. So we treat all by ourselves. But in medical colleges or here in urban big hospitals, we usually for small things refer to this, refer to that. So we better try to gather some information and try to treat 90% of the things that we can to the patient, and look like for these other symptoms and other things that we can help them. है ना? So this is, I think this is the last case, and then finished with this treatment we already discussed. And so thank you everyone. I think we are over with our panel. And anything, so take home messages by each one of us. Rekha Di, we'll start with each panelist. Take home message. Kalyani Di, you start. Bas ek, just to treat an anemic patient, how do you manage? Bas one line take home message for us.
Good nutrition and the iron therapy. Better you give the oral iron, but that is cheap and convenient for the patient, and she can take it regularly. So if patient is not in the last trimester, we should start with the oral iron therapy and the good nutrition. And we also must investigate the case thoroughly. What was the reason of the anemia?
So my take is that instead of doing only hemoglobin, we should do a CBC. That gives us a broader vision and helps us to classify the anemia. We see many gynecologists writing just hemoglobin. So now it is better that we write a CBC. So that gives a better idea of what is the type of anemia.
We will do CBC. And if it is a case of persistent chronic anemia, suppose after 1 or 2 months of the therapy, then we do also the other tests like this electrophoresis, HB electrophoresis, and the total serum iron profile.
Dr. Nidhi?
Always awake awareness among the patients themselves that this is a very deep clinical scenario and they need to be very careful for their anemia levels. They should understand the importance that if they don't care for themselves or their levels, then they might face complications and deliveries, which might be detrimental for them and the fetus as well on a long-term basis. So that awareness should definitely be at every antenatal visit. We should make them aware of what important it is.
Thank you. Dr. Monica?
For me, it is prevention is better than cure. I would rather not let the patient into any kind of emergency. I would like to treat her anemia for whatever reason it is. Whatever kind of time she comes to me, whatever measure is appropriate, I'll tell her. If it is supplemented by diet, then go for good dietary advice. If injectable necessary, then go for that. And if blood transfusion, go for that. But I would not rather land her up in any kind of emergency at the time of delivery. So prevention for me.
Okay. Now, Dr. Rashmi, unmute yourself. Unmute yourself. Till then, Dr. Babita. Unmuted. Dr. Rashmi is unable to unmute. I think the technical team tried to see.
Yes, ma'am.
So finally, actually,
Rashmi, ma'am, I have sent you the notification. Just click on that.
Dr. Rashmi?
I have asked to unmute. Yes, yes.
Yeah, I'm audible.
Yes.
Proper
Yes, ma'am.
counseling, investigation, and treatment all are required in combined way. This is the take-home message.
Thank you. And so by this, we can reach an anemia mukt Bharat that our Foxy President this year, his main theme is after this in a big way for Nana anemia and anemia mukt Bharat. So we gynecologists, obstetrician, we have to learn lots and lots, and we keep on learning every day from every patient. So thank you all brilliant panelists and my co-moderator, Dr. Rekha Jha madam, and really lovely having the day-to-day scenario type of discussion. Thank you very much.
Thank you, ma'am.
Thank you so much, ma'am. Thank you, Supriya ma'am. Thank you, Rekha ma'am.
Thank you.
And special
At least we went through the guidelines for a common topic like anemia because of this panel.
Yes.
Common. Yes, thank you to Rekha ma'am, Supriya ma'am, and all the panelists. And special thanks to Bharti ma'am as well for her special inputs in between whenever she got time. So thank you
Yes,
for the
yes.
lovely panel discussion. Thank you to Pratibha Singh ma'am as well. She was there for a short while. She had to leave for another webinar. We will move on to our talk, which has been pending due to the technical glitch that we had earlier. We are now all set and ready. With the blessings of Bharti ma'am, we will go ahead with Dr. Mangala Vani's talk. Dr. Mangala ma'am, the stage is yours now. Please go
Yes,
ahead with your
I will just try once sharing this my screen. Can I try?
Yes.
Yes, ma'am.
I will
Yes,
try
ma'am.
once. Can you see now?
Yes, ma'am. Just make it full screen.
Wow,
Seen, ma'am. We can see it now.
great. Okay, so
Yes, perfect.
thank you so much.
So
there
trying
was
can do
technical
anything.
glitch.
Now we are seeing the moon landing.
Yeah.
So it is possible. So she has landed.
Yes.
I tried different way and it happened. But that's fine. Wonderful panel discussion. Actually, I enjoyed to learn more things about anemia. You know, even breastfeeding prevents anemia in mother as well as in baby. Because it prevents the postpartum hemorrhage and the bleeding after delivery. And there is a better absorption of the iron in the baby with the breast milk. So it is just the amazing stuff. So if you see India, you know, we're supposed to think that breastfeeding is friendly, our country is. But if you see the figures, you know, the results of inadequate breastfeeding, it is just astonishing. More than 1 lakh babies, 34 lakhs diarrhea, more than 24 lakhs pneumonia, 40,000 cases of obesity in children, the breast cancer nearly 8,000, ovarian cancers, the diabetes in the mothers. We can prevent so many things. And see, per annum, our India, this costs 875 crores. So it has a huge financial impact. This is a World Breastfeeding Trend and India 2018. I mean, I won't go in details, but this is the BFHI. And we are very, very low in BFHI. Now, BFHI is Baby Friendly Hospital Initiative. Now, this was the extension of our World Breastfeeding Week. And the objective is just to bring awareness about the breastfeeding. And the Foxy is doing amazing now. There is so much awareness everywhere in all states, every single hospital now breastfeeding activities going on. So first 1,000 days, the most important. And if the baby does not get proper nutrition, the effects are damaging and permanent. They are irreversible. And it goes across generation. You know, the most important benefit of the breastfeeding is baby's brain development. The baby's IQ is higher. Now, I won't go into this, but if you see the research, the anthropologists, they have previously speculated that the natural age of the weaning is between 4 to 7, based on behavior of the other primates. And fossilized teeth reveals early humans breastfed for around 6 years. Now the WHO recommends the breastfeeding is minimum 2 years. That is still the baby's second birthday. And many of the health professionals, even they say, 2 years, that is too much. एक साल के बाद तो बच्चा सब खाता पीता है. And then mother is working, so no need. But the longer the breastfeeding, the more the benefits, you know. So if the breastfeeding rates are low, what is up this baby is asking? And the answer is for us, for health professional, to improve the hospital practices and make the hospital baby friendly. It is a global initiative and it transfers the hospital and maternity facilities through implementation of the 10 steps. So basically the UNICEF and WHO, World Health Organization, they have the guidance and they have implemented these 10 steps. And whoever follows these 10 steps, they get this baby-friendly hospital initiative, and the breastfeeding practices, they improve tremendous into this. So first in 1989, There was a joint statement by them, and ultimately in 98 they published the guideline about these 10 steps. So adherence to these 10 steps positively impacts the early initiation, exclusive breastfeeding, and total duration. But you see, only 10% of the births occur worldwide in the baby-friendly facilities. So if you see in India, it was launched in 1993, and according to the Breastfeeding Promotion Network of India, only 10% of the hospitals are baby-friendly. So it's very, very low. You can see the research clearly says the success of breastfeeding is much higher once you implement these 10 steps. So these are the 10 steps which are put in 1998, but there is an improvement in 2018. These are the revised guidelines. So I will talk about those. So these guidelines about these 10 steps, the step 1 and 2 is critical management. And then the step 3 to 10 is key clinical practices, that what we have to do about the breastfeeding clinically. So the step 1 is divided into 3. And the first one, most important, comply fully with International Code of Marketing of Breast Milk Substitutes and relevant World Health Assembly. So we have this IMS Act, that is Infant Milk Substitute Act. And then we should have the written breastfeeding policy and establish ongoing monitoring. So what does this act says? It prohibits the promotion, the display, advertising of their product or their any logo. We are not supposed to take any gifts from those formula companies, no free samples, no subsidized product, and no donations from them, or no coupons, no sponsoring for any conference, or we should not even have a lunch if there is any sponsorship program by them. They should not put the picture of the mother and the baby on their brand, and no sponsorship, no commission. Because if we take anything from them, then we become obliged to write the formula, to the mother and the baby. So it displaces the breastfeeding. Next is the hospital policy. Every hospital should have a policy which is routinely communicated to all healthcare staff and also to their patients. We should be written in the local language, and it should be displayed in areas where mother and babies are cared for. So the friends, world is not dangerous because of those who do harm, but because of those who look at it without doing anything. And this is particularly about the formula. Third is the monitoring. So hospital has to monitor how much is the early initiation and how much is the exclusive breastfeeding at discharge. The second is the antenatal, the staff should have the adequate knowledge. Not only knowledge, the competence and skills to support the breastfeeding. So all those skills, the positioning and attachment, the counseling skills, the expression of the milk, the cup feeding, the initiation of the breastfeeding within 1 hour after birth. If the baby is crying, what to do? If the mother says, I don't have enough milk, can you able to see whether the milk is really less or whether the mother thinks the milk is less? The problems, the premature babies, so once the staff training, definitely the practices improve. Minimum 18 hours it has been suggested, but at least half a day training per year, because the staff is always changing. And these are the key clinical practices. So the third is importance of antenatal breastfeeding class. We have to discuss the importance and the management of breastfeeding with the pregnant women. We have to prepare them. We can't tell them after delivery. And even if we just, say something in the clinic, we don't have enough time. So it has to be separate class for 60 minutes or even 120 minutes. And all those, the benefits, because once the mother knows about the benefits are not only to her, it is also to baby, to family, to environment. It is so environment friendly. I mean, it is a topic to itself. I think next year on World Environment Day, we need to talk about this. And, to the nation, ultimately, the babies are brainy, the babies are healthy, and the nation is going to prosper. There are so many 5-year millennium goals we can achieve simply because of the breastfeeding. So we need to discuss all those things to the mother during the pregnancy. Then the fourth is facilitate immediate and uninterrupted skin-to-skin contact and support mother to initiate breastfeeding as soon as possible after birth. So regardless of the mode of the delivery, whether it is normal delivery or whether it is cesarean section, even in the preterm babies, if the mother are separated, the colostrum should be expressed within 1 hour, because longer the time interval between the expression of the breast milk after delivery, the less chances of success of the breastfeeding. The colostrum is so important for the baby, and the baby has a very good suckling reflex. So if you put the newborn baby to the breast, there is unlikely that the baby will have a latching problem. The next step is we have to support the mother to initiate and maintain breastfeeding and manage the common breastfeeding difficulties. So that is why the staff has to have the skill. They have to know what is the proper latching, how should be the position of the baby, how should be the position of the mother, how the mother should hold the baby. Like when we conduct the workshop, actually half day goes only telling this, and we have a 3 days hands-on skill workshop where we teach the health workers how to have this. So it is a skill and it is a training that everybody has to do. Most of the breastfeeding problems are caused by poor attachment of the baby to the breast. Thus, it is vital to learn how to feed the baby with correct positioning and attachment. The next is another important: do not provide the newborns any food or fluid other than breast milk. And this is the most problem, because initially the colostrum is a very small in amount, sometimes few drops or 1 spoon maybe. And then everybody thinks this is not enough for baby. See, when nature makes something, nature never goes wrong. There is a purpose behind that. So, and baby's stomach is also very small. So if frequency every 2 hourly that baby is put to the breast, then baby keeps suckling, and the newborn term baby has a lot of glycogen storage in the liver. So that glycogen gets converted to glucose and the baby's sugar is maintained. So we don't have to really worry about the hypoglycemia. Pediatricians, they are worried about the hypoglycemia, and that is why, immediate the formula is given. And it is 30 ml when the baby's stomach is so small. So what happens? The stomach expands and the baby wants more and more. And then it's really less. And then when there is no stimulation to the breast, when the milk is not coming out, automatically the calibration of the milk supply becomes less and mother's milk really becomes less. So initial 2-3 days are very, very, very crucial. Of course, we have to monitor. We have to monitor, make sure the position is all right. She's feeding frequently. We have to monitor how her urines are, how is the stool, how is the weight, because the baby should not lose more than 7 to 8% of the weight while in the first week of the life. The 7th is enable mothers and their infants to remain together and to practice rooming in. Means the mother and the baby should be same room, not only same room, sometimes we say bedding in, means close by, so that the mother can recognize the early cues. Whenever we ask anybody, how do you know baby is hungry, they say crying. But the crying is the last cue. And by that time, the baby is very irritable and the baby even may not latch properly. So early cues we have to teach them, and so that then the mother feeds frequently, effectively, and there should be no restriction between their contact. Even the baby is separated. If baby is in NICU,
mothers should be allowed frequently to go to NICU. In fact, we recommend there should be beds in the NICU campus where mother can rest so that, she can frequently express or breastfeed or give kangaroo care. Support mothers to recognize and respond to the infant's cues feeding. That is what we discuss. The next step, the 9th step, is counsel mothers on the use and the risk of feeding bottles, treats, and pacifiers. And many times we see the pacifiers easily gone in the baby's mouth. Or sometimes they take that nipple shield, put into baby's mouth, and put the formula with the dropper inside. I have seen this many times in the hospital practices. So baby gets confused. And plus the easy flow in the mouth, then the baby does not want to make the efforts. That is a human tendency. Anything comes ready-made, you don't want to make the efforts. So we should, and it is again very difficult to sterilize 100% those nipples. Ideally, those nipples should be changed every week, but it doesn't happen practically. And the babies, the express milk, babies can take nicely with the spoon or directly by the cup. We actually do this training about even cup feeding, how to feed the baby with the cup. And it is, amazingly, the milk is not spilled and the baby takes nicely. The last step, coordinate discharge so that parents and their infants have timely access to ongoing support. Now, when this mother goes home and if she has a breastfeeding difficulty, she doesn't know where to go. Does she have to go to obstetrician? Does she have to go to pediatrician or general practitioner? And who are they skilled? It is very important that everybody has the knowledge, everybody has the skills. And so that is why now the lactation consultants are coming into more picture. So they play a very important role in the hospital as well as in the community. So there are mother support groups, mother to mother support group. In Pune, we have a nice mother to mother support group where the mothers come together, and they see each other breastfeeding. They give tips to each other, and it really, really helps them. Because nowadays with the nuclear families, so many mothers haven't seen even anybody breastfeeding. If something which we haven't seen, how we expect that we will do? So this mother to mother support group really helps. The lactation clinics, again, very, very important role. And even the new BFHI, that this BFHI practices should be adopted in the NICU. So the attitude of the staff has to change. And if the baby is unable to breastfeed, feeding with exclusive breast milk, or the second option is the donor human milk. So every hospital is expected to have a human milk bank. And if unavailable, then only infant formula is the option. And then appropriate feeding methods and use of bottles and teats negatively affect the breastfeeding in preterm babies. So it is a cup or tube feeding, very, very important. So on behalf of BPNI Maharashtra, we do this baby-friendly certification. We give training to the hospitals and we assess the hospitals. We give them some time to improve their practices and we give the certification. Another thing we do is this IBCLC training. What is IBCLC? It is International Board Certified Lactation Consultant. This is the master's degree in breastfeeding, 1-year program, and that training we give. So just yesterday, I finished this year's course at the Bharati Vidyapit Medical College, and we had 90 students from all over India. So that is how the knowledge will spread, and each hospital will have somebody specialized, in the breastfeeding. So friends, conclusion, the role of health professional in IYCN, that is infant and young child nutrition, is very important. By having knowledge and skills, we can help mothers to breastfeed successfully is so important. Not just little feeding, little formula, just 3 months breastfeeding, then completely formula. Or when mother goes to work, she stops breastfeeding. When she gets upset, she stops breastfeeding. When she gets, lots of problems. So she can cross all the barriers. Even we now induce the lactation in case of surrogacy, where mother is not pregnant, she has not delivered the baby, still she can breastfeed. So the science has advanced. So, we should make use of that. And we had to, I think every mother and a child have a right to breastfeed. And the BFHI certification definitely improves the breastfeeding mothers. Thank you so much.
Thank you, Dr. Mangala, for such a nice demonstration of so much of importance in all breastfeeding. So many new things also I have learned from you. One is that you told to continue breastfeeding to 6 to 7 years. Practically, when the patients are continue beyond 2 years, I am irritated. It's my fault.
At least 2 years they should be.
Because why? Because they have not taken care. During the lactation, the mother should take also iron, calcium, that they don't know. They started having the depletion of the iron and calcium, and they require more calorie. In our side, they don't give the postnatal mother lot of food, less water they'll give, less protein, less everything less. Which
There's
is
so many aspects.
one and a half time. Unless they give that and they continue breastfeeding for 2 years, 3 years, they have a backache. Sometimes with a prolonged breastfeeding, the patient will have a teething and they do a injury to the breast and breast abscess also seen.
Nipple trauma, yeah.
Learning from you, we also can give a protection for lama or lactation, amenorrhea and contraception. But that has to be also told that mother also has to be given more nutrition, more calorie, iron and calcium supplementation. One thing. Second thing, another important factor we have told that there are two types of feeding. What we have learned and we are practicing. One is demand feeding, when the child will cry and demand, or timely feeding. So before the child cries, one thing she has told that Mangala has told, before that you give. Because so many times I have seen, I love to give baby and mother's latching and other things when after delivery. But when I see that baby is very much irritated, they will refuse.
Correct.
I tell one thing to my practical thing, I don't fear to do delivery as CS, but I fear on second to third day, the mother will complain, no feeding is coming, no milk is coming, and you press, the milk will fall on you. They'll be telling like that. So what I have seen, baby has been snatched on the other side of breast and mother will be holding, the mother of the patient. Like that, because they have to do, and I tell one thing, funny thing, that if the cow is giving, if the dogs are giving, if the elephants are giving, if the animals are giving, like tigers are giving, why not human beings?
Yeah, the donkey never goes to the monkey and asks for
Homo sapien are the most intelligent and they know everything. And you are telling that they cannot give, my daughter is innocent. So that learning has to become in the antenatal period. And as you have suggested, that group of lactation, rightly pointed out, because nowadays everybody has become modern. For that reason, the breast cancer is increasing in India. It is in 1 in 8, 1 in 9 in USA. And it is the first cause of death, breast cancer ovarian. In India, it was cancer cervix. But breast cancer has come up because of we are learning them, we are imitating them. Less family, less lactation, and working women, like that. But that's also best. Another things we have to told that we have to have a feeding. Suppose a baby is dying and our mother can give every BHF hospital should have a storage for breast milk, so that we can give to the mother, those who are not lactating, had disease pregnancy, mother died due to PPH or any other things. Breast milk bank has to be there. I don't know whether it's a protocol of BFHI or not. BFHI also should include the breast milk banking in every hospital, isn't it?
No, it is not compulsory for BFHI, but that is a good idea. But suppose the hospital is small, then it may not be
tertiary hospital we are working. So big one, lot of problem. NICU is full of babies, small babies and everything.
They should
If
have
the mother cannot come, if we are having a breast milk bank, and mother cannot go also, that milk also we can provide them to the pediatric ward to give them. That would be a good idea. I'm just suggesting. So thank you very much. Anybody have any doubt? Mangala is so clear and such a nice subject. And that training is only for MBBS doctor or PG or what? What 1 year training?
Anybody who is interested can do this degree. As long as if you have a science degree, even MBBS, PGs, we have even HODs coming to join the course.
Nursing staffs.
Nursing staff also they can do.
And another things you have not told, what are the things that prevents? First thing it prevents is the accumulation or attendance. That I tell you. I was working 1 year in Vellore, CMC Vellore. Always I am funny. I like to put flowers on my head. And in Vellore, lot of jasmine flowers. I put them. I always put one. Maybe artificial, maybe that one. Same thing with me. See, both of you are same. And it stays for 1 month. 31st August, my husband's birthday, I kept it, and now it is there in my book. So I kept it because matching. Leave it there. So I put one jasmine and went to the hospital. The student nurse there told me, "Madam, you cannot come." So I was astonished. I was new to that place. Why? Because even the smell will prevent the breast milk. Attendance. I told in the combined ward that male attendant, one attendant is husband of other, but she is not husband of the wife, not other, no. Inhibition will be there. So that also they should understand.
The visitors should be
everything, when sites should be given, burping, everything has to be taught. Thank you very much. Without taking more time, already we met and done very nicely.
Thank you so much, ma'am. I think it was worth the wait. We had to wait to listen to Mangala ma'am, but it was worth the wait because it was a really nice lecture, Mangala ma'am. Very nice.
I can elaborate, but with the time, I think each step we have to have at least one lecture. So I think through Foxy, you arrange more and more and we'll dispart this knowledge.
And nursing staff also can take this training, no? IBB,
yes. IBCLC, yes. You can just contact me anytime. Even if you have more than
I would also like to thank you, Dr. Mangala.
We can get this training done in your place there also.
Dr. Mangala, I would also like to thank you very much on behalf of this PAC committee and on behalf of the East Zone. Yeah. So it was a really nice presentation. So thank you, and thank you, Dr. Bharti Mishra. So nice meeting you on a virtual platform like this, and hope to make friends with you later on.
Yes.
So
yes, ma'am.
Now?
Thank you so much.
This is the beginning.
Yes, ma'am. Ma'am, you can get the vote of ma'am.
So we are ending.
Ma'am, you are mute.
Okay, so this is the
yes,
end.
Ma'am, we are done almost.
Any other talk is there? So okay. So I enjoy.
No, there were 2 talks and 1
really. These are the route which we should discuss. We are discussing about IVF, laparoscopy, and everything. Breastfeeding, anemia should be discussed more frequently, which is more practical, which is necessary for the good mother. And for anemia Mukt Bharat, I have done in 6 to 7 times in different places the hemoglobin estimation, and you will be astonished in the higher community also, business group, 20% were anemic.
Yeah, even higher class also.
Just awareness the quality of the food, what type we take. So nowadays also I am advertising the sprouts and also chotwa, all the powder mixed and given. In your side is more, in Patna, isn't it? Patna, everything more people are there. So in that side, chotwa is very nutritious. It is a poor woman proteins, isn't it? Why we give protein powder? Why not natural government supply? Isn't it? Hats up to the government who is supplying egg, iron, and also the powdered grains, isn't it?
Right, ma'am. Thank you so much, ma'am. Rekha, ma'am, would you like to give the vote of thanks, ma'am? We are at the end of the webinar.
Satabdi, thank you very much.
Yes.
Please take a screenshot and send, because it is required
put
for
it on
my
the group.
academic group. Okay.
Surely,
So,
ma'am. Surely, ma'am. Our technical team will be having pictures. We'll share them, ma'am. Definitely.
Bye to everybody.
Rekha.
Yes. So on
Ma'am.
behalf of the
Yeah.
Public Awareness Committee, I thank the office bearers of POGSI, Dr. Pai, Dr. Madhuri Patel, Dr. Alka Pandey, Priyankur Rai, and Dr. Kalyan for bringing this platform for the East Zone. And I would like to thank Dr. Pragya, Dr. Shyamal Seth, and I would like to thank our speakers today, Dr. Mangala and Dr. Apurva Datta, and all the chairpersons, and especially Dr. Bharti Mishra, who has been with us till the end. And I would like to thank Dr. Supriya Jaiswal, who took all the pains to prepare a panel on anemia. I was just added into it in the last moment. I have done nothing. She has done everything about it. And so thank you, Dr. Supriya, very much. And especially a special thank you, Dr. Kalyani Singh. She, being a senior person, she was very good as a panelist. And Dr. Monica, Dr. Rashmi, and Dr. Devanjana, and Dr. Nidhi, and one more panelist, I don't recall the name, Rashmi, Dr. Rashmi. They were all very good. We had a very healthy and
Forget the Corona group.
yeah. Yes, in the
Corona
last
group, the host.
and the
Thank you,
Corona,
ma'am.
they have become a family through these webinars. They are almost a family with us, and they have been conducting all these webinars very efficiently. And I would like to thank Dr. Priyankur and Dr. Indranil, who have been always there, off and on, according to their engagements. They have been coming to the webinars on the virtual platforms, and everything has been going very smoothly. And we are very happy to conclude it in a nice way. And Dr. Mangala, you were excellent. In the end, I would like to thank you once again. So thank you. And in the end, Satabdi, she has been the best coordinator. She has been doing it effortlessly throughout in all the meetings, in all the PSC activities. And we missed Dr. Monica today. So thank you, everybody. Thank you very much. Okay. So bye and good night.
Good night, ma'am.
Good night, everyone. We'll see you all. Thank you, ma'am. Thank you, Abhishek.
Thank you, ma'am.
Yes.
Thank you, everyone. Dr. Supriya here. Dr. Satabdi, lots of thanks to you.
Thank you, ma'am. Thank you, Supriya, ma'am, for patiently conducting the panel, ma'am. Thank you so much.
And
Thank you.
Rekha, ma'am, thank you so much for appreciating me. Thank you so much. And Team Corona Remedy.